Hello, lovely people. Welcome back to Priya's England Diary. So we've got a very senior nurse, Peter Bramfield, with us. Hello, Peter.
Namaste.
That's so nice of you. And thanks for coming in and coming into the Equipment to make a video with me so that we could educate nurses out there sitting in India that what are the things expected from them when they're coming to UK to work for the NHS. All right. So it would be really nice of you if you could just give us a little bit of background of yours and a bit of introduction, so we would know about you a little bit more.
Certainly. Hello. So my name is Peter Bramfield, as Priya said, and my title is Lead Nurse for Quality Education and Technology at the General Intensive Care Unit, University Hospitals, Plymouth, which is all a bit of a nightmare. I've got 36 years experience working in intensive care, of which 24 of them have been here in Plymouth.
That's so nice to hear that. So I'm very, very nervous because right now I'm sitting with a nurse who's got 36 years of experience working in the critical care unit. All right. So
That's older than you, I would imagine.
So let's just start with you. So Peter, we would just like to ask you a question. What would be your opinion, thinking about the transition of nurses from India to UK? What would you think about that?
Okay, well, we were discussing earlier, we've got a lot of experience of having internationally recruited nurses, and we have been recruiting internationally for at least 20 years now, never in quite the large numbers that we had in the last year. I think in terms of, we do have a lot to offer, and we have very clear pathways for people who join us from overseas. So you should have had the introduction of an international recruitment team who would have sort of settled you into the UK and they help you set up a bank account and get those first steps done. Then you would have come and joined us. And again, we have very, very clear sort of structures in place that we want. So first of all, you're going to be spending a large period of time working with a buddy, with a mentor, I should say. And that will be anywhere, well, really it's about getting your OSCE and getting your UK registration, nursing registration sorted. Once you've got your registration, then we're thinking about probably a further 6 weeks working absolutely all the time under the supervision of that buddy in order to get you sort of up to speed and very familiar with our processes, the way we work, where information is on our systems, etc. If you were joining the intensive care from the UK, you'd get 6 weeks minimum. That is about to change, and we're going to have national guidance saying you should have 12 weeks, 3 months of working, one-to-one with somebody. Once you are then beginning to practice a little bit more independently and on your own, you're always going to be buddied up. You should be working closely with the people you're working next to, and then you're going to have very, very close supervision from the shift leaders, and then also our band 7 ward managers, etc. as well. And we have our clinical band 7, so to provide support and training. Would now sort of then, shall I go on and talk about the national structure?
Yes, that would be nice to know.
So when you come in as a new nurse into intensive care in the UK, we have a series of steps, and they're booklets at the moment. And the idea is you'll start the step 1, and it's part of the national, I'm going to get the term right. It's the National Framework for Adult Critical Care Nurses. And step 1 is you're meant to try and achieve it within the first year. And this gives you the basic skills and knowledge to work within an intensive care. And there's bits within that are coloured in purple. And the idea is you do those, and then you're ready to sort of be working on your own a little bit more independently. The idea is you finish that. Once you finish step 1, you're then ready to move on to steps 2 and 3. Now, steps 2 and 3 are actually meant to be tied to an academic course of study, and that course is meant to be 60 credits. It can be at what's called level 6, which is degree level, or even level 7 master's level. And now you come out of that with either a diploma or a postgraduate diploma in critical care nursing. And so there's an academic component, and then there's also the practical, the STEP competencies that you need signed off. Once you've completed that, there are further steps. So there is a step 4, which is all around sort of management, leadership, leading shifts, etc. So all our band 6s who lead shifts will be either have completed the step 4, we're about to start doing them. And then there's also specialist competencies. So again, these tend to be what called bolt-ons. They're done after you've completed the critical care course, and there's the specialism such as cardiac surgery, neuro, trauma, burns. We don't tend to do the burns ones here because we're not a burns unit. There's maternal ones, there's outreach ones, and there's also step competencies for ward staff who are dealing with what we call the level 1 patients. So they're not quite sick enough to come into a critical care or an ICU, but still requiring a lot of care on the wards. So there is this whole framework is in place to give a structure. So, you will have a nationally recognised award, and these, you may have come across them before. I mean, these steps are available on the internet, and they are used internationally as well as within the UK.
All right. So it's not just for our trust, it's being all over the NHS in the UK.
So, if you now decide you want to move down to Truro, and you've completed your step 1s, they'll recognise, okay, yeah, you're an experienced ICU nurse. You've completed the step 2 and 3 and done the academic study. Ideally, you'll be more ready for the next step. Yes. And not next step, but the next pay band, really. You should be recognised as a band 6.
Yes.
Yeah, as a specialist nurse.
So the other thing I would like to ask you is that, basically, with the Asian nurses, is there anything in particular, any issues you've been, not just you as a whole, as a trust, you've been encountered any issues with them and you think that we can work on it? So would you like to share any of such experience?
So I guess you're talking about cultural things. And yes, there are very, very clear sort of cultural differences between perhaps people from the UK and people from the Indian subcontinent. And I think one of the big issues, although it hasn't been the case with you, is that perhaps a lot of our IR nurses perhaps are used to perhaps a hierarchy and not answering back and not sort of putting their hand up and going, I don't think that's a good idea, or interacting quite that way. And you sort of expect that if the medical staff, the doctors say, do this, well, you just go and do it. And actually, we're a lot more, we expect a little bit more interaction and questioning and so on. And I would like to think that in our medical team, they recognise that you're the people at the bedside there for 12 hours. You should have a very good handle on what's going on with that patient, and they're relying on you to pass that information to them. And because they're just coming along and they're getting a snapshot. And they might see, a person who's looking, with hyperactive delirium, just lying in the bed, not doing anything, and they think, all right, okay, hyperactive delirium, we don't need to be too worried. But you're the person who spent the last 10 hours trying to keep their hands down away from their tubes and wires, and they've punched you and pinched you and trying to bite you, and you're all frazzled. But they're not seeing that. You need to be telling them. Yeah.
I think the communication needs to be two-way. It's verbal, of course, and needs to be as well as written form. Yeah. So once the doctor come in and they're just going to look after the patient for, I think, maybe 10 to 15 minutes of time, if we write things specifically, so they would have an idea once they're looking into the patients, all right, so this has been happening with the patient, and they could ask us more question about it. And I think if somewhere around, and I feel I'm not comfortable with any of the doctor's advice, or any of my seniors' advice, and I think that's not going to work out for my patient because I have been into the bed space for a long period of time. So I think I have got the all right to challenge them.
Yeah.
Do you think so?
Oh, definitely. Yeah. And when it comes back to this hierarchy, we know it is safer for our patients if we have a much more flat, that's sort of not a hierarchy, but a flatness, and we take everyone's opinion and make sure that the senior decision makers are listening to everybody, because it's very, very easy to sort of miss important information if you're just thinking about, well, I'm only going to listen to myself and anyone else. And I guess you were saying it's two-way, and it is two-way, because it's also very important that, if you don't know something, that you're raising your hand and you're going, well, I don't know what that means, or I don't know how to do that, or what the hell is that you're asking? And so it's got to be two ways. And bring it back to the question, I think perhaps a lot of our internationally recruited nurses have been a little bit reticent, a little bit quiet, a little bit mouse-like, and don't like to ask questions, don't like to raise objections, perhaps feel it's not their place to pass information on or challenge. And that has been one of the biggest hurdles. Yeah.
Because when I came in the intensive care unit, I felt the same way, and I just thought that if I would be passing my messages to someone senior, they might not validate that. But with time, understanding the cultural, I have got to learn that every human, doesn't matter band 3, band 4, band 5, whatever, is matter, and the opinion does matter here. So that's what I have come across so far.
Good. I'm glad to hear it, because we know it's a far safer way of working if we listen to everybody. Yeah.
So, any other issue is there that you would like to highlight a bit more about it?
Let me have a think. Certainly, I think I've already talked about the need to, if you don't understand, please, say so. We're not. I'm sure there'll be one or two people who might be going, "Oh God, not another bloody question." But the majority of us will be understanding. If you don't understand, but rather you said, "I don't understand. What is this?" question, rather than just keep quiet. You can muddle through. That is probably the key lesson I want people to take away from this. Ask, talk, interact. Can't go wrong. Yeah. And I suppose I took my son up to London recently. Okay, and I was showing him around. His name's Denzel. And we saw this great big building. And he's going, "Oh, Dad, who lives there?" I said, "Ooh, Buckingham Palace." "Sorry, Denzel, no idea." And we walked down the road a little bit, and there was a gate and policemen and stuff. And he said, "Oh, Dad, who lives there?" "Downing Street." "Sorry, Denzel, no idea. Haven't got a clue." And we were around, we saw the Tower of London. Wow. And he said, "Oh God, that looks like a fort. Is it still used as a castle, as a fort?" "Sorry, Denzel, no idea." And we saw this great big bridge and things that looked like they lifted up and down. He said, "Oh, Dad, what's that called?" "Sorry, Denzel, no idea." And then he goes, Dad, do you mind me asking questions?" I said, "Oh, Denzel, how are you going to learn if you don't ask questions?"
Actually, this is a very nice experience which you have shared with us, because when I came as an international nurse here, I did have this question back in my mind. If I keep on asking them questions, they might think that I'm very needy. But then I realized, I need to, otherwise I wouldn't be learning. It's always safer than being sorry. So, meanwhile, I did have my appraisal session with Richard, one of the band 6. So, while I was just having a chat with him, and I came across sharing my points and opinion with him, and then he was like, "You need to ask questions, because if you don't ask questions, either people may presume, they might think that you know all or you know none." So then I did ask him, I did have some experience back in India, but still sometimes I do struggle with the procedure and other stuff, and I feel like always taking help from the next door body, but somewhere down there, I feel like they might be thinking about me that I'm very needy and I keep just asking questions. Then he did share his experience, saying that he did have a quite good number of experience back in London as band 6 nurse, and he had been managing the shift around there in the intensive care unit, a very busy intensive care unit. But when he came down to Plymouth, he did feel that he was just starting from zero. And he said that I also felt the same way what you are feeling. I had been asking people a lot of questions, and I've been always needy. And I also went through the same feeling of feeling embarrassed. I am asking so many things, and what they might be thinking, what kind of experience he has when he know nothing. But yes, I did the right thing, asking questions and finding out the things that I am competent enough and able to manage the intensive care unit as a shifting charge. So that experience, what he shared with me, made me more confident in me that asking questions does no harm. And anywhere in the world we are going, one or two people will be there who might not be liking the idea of asking questions, or they might just think that we are very busy and she's just...
Oh, they're just right at that moment, they're in the middle of doing something. I've got to do this. So.
Yes, could be, but it's always better to ask question and learn.
Yeah.
That's what I'm thinking.
So, two things I was going to, say to that. I've done the rubbish joke around, if you don't ask, you're not going to know. And actually, another sort of cultural thing is, and I think this is very Indian, I might be very wrong about this, but almost like you don't like to say no. So I might ask you, do you understand? And you really don't want to go no. So you go,
Yeah, I don't understand.
No, I don't understand at all.
Yeah.
And so I guess in the UK, you sort of expect a direct, no, I don't, I've got a clue. What are you going on about? No. And and sometimes you notice it, and I've seen it, I thought I've explained something, and I'm thinking, no, you haven't got that. And I go, do you understand? Have you got it? And they're going, yes. And I'm thinking, I'm not sure you still want to upset me, is it? Do you think that's true?
That's 110% true. Because you know what happens? Like, I have also seen people a lot of time. It's just with me. When I came in new here and when I couldn't understand anything, especially the accents. So
I was going to ask about that.
Accent. So when I came in the ICU and I was just like felt like I'm just watching a Harry Potter series around me, everybody talking in that accent, and why the hell I'm not able to understand things what they are talking about? Like, I have done my English proficiency and I have passed the test, and why still I am unable to understand? It made me really frustrated. But with time, and I did feel ashamed to ask people, like, "Hey, sorry, could you repeat that again? Sorry," because I would be thinking what they might be thinking about me, asking them again and again. So even if I didn't understand anything, I would be like, yes, yes.
And that's a two-way thing, because I sometimes, a lot of RIR, internationally recruited nurses, one or two, you're thinking, and I'm getting older, I can't hear very well. And it's like, what's that? I'm a bit embarrassed to ask them to repeat it for a third time. So I'll go, yeah, I've got that. And perhaps in the education role, it's not quite so important. But I think if I was working clinically, I'd have to be going, steal my guts and go, I'm sorry, I really didn't catch that. Could you repeat it? So with time it settles. It's not a big deal because initially when I came in and I really thought it's going to be a very difficult time for me to working here without even understanding the people talking around here. And the best thing, I couldn't understand the jokes. People would say something and laugh and I'm like, what was that? But now jokes are very culturally specific and the words and things are very different. But with time I have got my hand around already and now my ears got so used to. So the other day I was just watching a news channel, BBC, when I was back in India preparing for my English test. I used to watch BBC and I really had to struggle to listen what they are trying to say. And now with my closed eyes and I can relax and listen to BBC what they are talking. So I think it's just because nothing related with the language what I have studied back in Indian. It's just the accent. So we can only get to the accent listening to people. If I'm just gonna be quiet, immersing yourself in the UK, you're getting around the culture and trying to adapt to the environment, and it takes time. Maybe for me, it just took me, I think, another 2 to 3 months of time. But I'm okay now, and I can understand. Earlier, if you could talk to me 2 years back, and I would be very nervous to talk to you. Oh my God, what Peter's going to say, I wouldn't get anything. But now I know I can understand what you're talking. It's just because I've been here for a number of years. That is more than 1 year, I think. So yes, I can get through it. Something I'd like to just pick on, you talked about moving. Mm-hmm. And so certainly in my career, I've moved around a little bit. Mm-hmm. And I've done lots of agency where you just pick up in London in a new intensive care, you have to work and that's it. And I know every time you move, it just feels like you're back at the very beginning again because everything, it's new monitoring, new beds, new ventilators, new ways of working. Sometimes even new acronyms and language and so on. And you just feel like you're back at starting all over again. But, we recognise a lot of you guys got a lot of experience in intensive care. And it's just like whether you've moved from India or you've moved from Exeter, which is the next hospital on the road, it's all going to be new for you and different here. Exactly. And what exactly happens, when moving to different country, the equipment and everything is different. That I totally understand. But is the ICU experience still help me a lot to pick up things faster? The principles of the same.
I think the principle along the all the same, looking after the patients, when the ventilation,
Caring,
the care, the looking after the skin and stuff. And it's more or less same. So
poo, urine, vomit, it's the same worldwide.
Blood,
The blood.
everything's gonna be the same. It's just with different ways of doing things, and even I believe so. The NHS is very, very structured in their way of doing things. But even if we move from one hospital, NHS, to the another hospital, there would be something different. Each hospital
Definitely,
practice would be some of the other thing would be different. If I'm not wrong, is that right?
Yeah, definitely. And the culture will be different, and
So
all sorts of things.
also,
Even if you go, 2 floors up, there's another intensive care unit, the cardiac intensive care, and you go and work there. I don't know if you have. If you go up and do a shift there, it's different.
It's different. Obviously, it's really different. So I think it's more of adapting to the work culture wherever we are working. So the fact is that it does take time to adapt. It's not gonna be overnight. It does take. It took me around 6 to 7 months to get settled in the ICU and start liking the ICU. So yes, it does take time. This is a very honest review. It's not the NHS. It's not any other hospital. It's just as being a nurse. If I move from one place to another, it takes time to get my hands on the world settling.
Yeah. Okay. I think you talked about wanting me to talk about another sort of NHS and taking on IR nurses, and so certainly something that came to mind is, we have had in the last 10 years, and then we hit COVID. We have had big recruitment issues, and so I would like to think we have made you feel very, very welcome, because suddenly we are now staffing so much better. We've got much more people on the floor. We have been struggling so much, and you guys have made such a big difference. So thank you very much for coming and rescuing us.
Well, thank you so much for letting us come in and work in this wonderful place among these amazing humans. What I feel is that being a nurse, when I came in here, feeling supported and safe is very, very important. So, in terms of, apart from the things you have spoken about, the structured way of handling the IR nurses is like giving them the induction pack and letting them know the things around, settling them into and getting in the accommodation and stuff, and as well as setting the bank account. So everything is being taken care by the NHS for the nurses. The major thing what I feel is, even after having such a structured way of handling the nurses, there is always a scope of improvement. And what I think it needs to be two ways again.
Definitely.
If the NHS is giving their 80% of hard work, effort, like giving the education team, giving per day, there are band 6 nurses on the floor to ask questions. It's become the responsibility of any nurse working on the floor to work on themselves as well. So I would take my personal experience when I was back in India. So I never used to look at the EBG much. Like mostly I used to be dependent on the doctors. I did know the normal values, but I never used my brain, what's going on, and just like giving them and letting whatever they're saying, and I never challenged them. But then after coming in here, I did learn those things to find out things, what's going wrong, figuring out what's going right with the patient, what's going wrong with the patient, and giving my opinion to the doctors. I think this would work this way. If you are happy for me to give, suppose I see the lactate going up, and I would just say, do you think that it would be a nice idea to give a bolus of fluid? So I feel so valued that my opinion is taken into validation. So those are the things I would say that helping myself or growing my knowledge with all the possible resources available from the NHS. It's become my individual responsibility. And yes, if I don't get the things done it in the right way, I could always approach to the right people.
Yes, so we have a saying in the UK, you may have it in India, you can take a horse to water, so we can provide all this education support and stuff, but we can't make the horse drink.
Exactly. So, this is in India.
Yeah. So we're relying on you guys to soak it up, take it on board, and work in the ways that we're used to and we're wanting to work.
And you might have noticed that I'm most of the time at the door of the education team. Like, oh, well, I can't do this. How to do this? How to find out.
Good.
So Yes, I feel if the resources are provided, it becomes an individual responsibility to make use of it. So I'm quite happy with the resources and the opportunities which the NHS is providing.
So tell me, you said you'd been here just over a year. What could we have done better?
Um, yes. So I think we have been provided with all the support, but it could be nice to have at least a yearly meeting or a 6-month meeting, not just individually, but with a group of IR nurses and being a manager or something, asking individual their hurdles, what they have been facing. Because what happens when we are alone and whenever I'm popping in and out the office, my manager tends to ask me, "Are you okay? Do you need anything?" But what I feel when we are in a group and one individual share the experience, the other might get encouraged to share the experience. And then
Safety in numbers.
yes.
So perhaps that's why we're not doing it. We don't want to be ganged up on.
So we have got the
Yeah.
few nurses
I mean, that's tricky to do, isn't it? Just because we're all, we're providing a 24-hour, 7-day-a-week service, getting a whole group of staff into the same place at the same time is quite a nightmare, quite tricky. But yeah, it's certainly we should be.
Maybe monthly, it could be yearly, just like reevaluation. Yeah, just letting them know, and then we talk about the hurdles and we could share.
I think this is often a big problem with the NHS. We're always dealing with the next problem. And, there's so much stuff we need to go back and review and look at and reflect on. But no, we've got to deal with the next problem. Oh, we've got to deal with the next problem. And I don't know, perhaps it's the same with you or your viewers. We had COVID, and we just carried on. And it's like the rest of the country will go, phew, we're out of that. We've just carried on. It doesn't seem to have slowed down or, COVID has disappeared. We don't get COVID patients, but we're just still running flat out. And so, yes, we're always dealing with the next problem and not having time to reflect on what we've done and what we could do better.
Since getting back to your question back again, the improvement in what you've been asking about from my side, I feel that we've got a number of access where we can always share about the feedback. We've got the freedom to speak. We've got a team where we can go individually to them and tell them things and they wouldn't share with anyone, the confidential team. So I feel like we've got the numbers of access, and if there is something, we can always talk to them and we can be provided with the solution. So I don't actually think there is a lot of improvement, because I see the international recruitment team has been working harder and harder for support the nurses, and then we've got the education team, we've got a manager and band 6. So nurses like me, those face problem, they are always open.
And we've brought in a lot of sort of band 7 clinical workers as well, or nurses rather, to support all our staff. Because we recognise we've got a very junior, compared to perhaps 10 years ago, very junior workforce. You're all youngsters.
And I'm still learning. I'm learning every day. So I think the intensive care unit is such a place where you can never learn enough.
No. You learn something most days.
Most days. Every day I learn new things. So yes, I'm crossing my fingers and I'm all ready to learn more things, new challenges, everything. And meanwhile, I'm just trying to make the nurses aware back in India what's going around here. And it's not that difficult to come and work here in the intensive care unit or any other part of the hospital. It's just like India. It just takes some time to settle in here and start working.
And I'd like to think you'll get a very warm welcome.
Thank you.
Thank you.
I feel so grateful coming into the NHS and working among these people, because working in the ICU itself is a very overwhelming experience. It doesn't matter whether you're in India or whether you're in Nepal or in any part of the world. It's just an overwhelming experience with the ICU itself. So if you get people around you, those who are always readily available to support you, it's a nice experience to learn and grow. So yes, I'm so grateful to the NHS and all of you guys, those who are helping us to grow and learn things and make a journey a little more easy and better. Thank you so much for coming in. It was nice talking to you. Thank you.
Thank you.